Hello, my name is Tony McLean, and I'm from Sydney, Australia, where I work in an intensive care unit at Nepean Intensive Care Unit in the western part of Sydney. And the subject today is actually, it's a very interesting one because it's one we sort of don't think about much, but it's how do we assess left ventricular contraction by using echocardiography and not just relying on the left ventricular ejection fraction. So before I go any further, I have to say that I have no conflicts of interest. When we look at the echo methods for assessing left ventricular contraction, the very standard way of doing it is the left ventricular ejection fraction. And this is really a hangover from the days of when cardiologists did most of the echocardiograms, and the left ventricular ejection fraction is a very important way of following the changes in the contractility of the left ventricle. And as can be seen by this picture here, here's a very poorly contracting left ventricle. Here's the right ventricle. Here's a pacemaker in the right heart. Here's the left atrium. But we can see this left ventricle is very poorly contracting. And the question to us looking after as critical care doctors is, how well is this left ventricle contracting? Yes, we know it's down. Is it down a lot? Is it down a little? And so let's just look at what tools that we have. Now, the left ventricular ejection fraction has been used for many years and for good reason. And I put up here a couple of cardiac studies. Here's one from the CHARM study, way back a few years ago now, but I choose it because of the large number of patients in it, 7,500 patients, where candesartan was used to evaluate its role in the treatment of heart failure. The important thing in this graph, which I put up, is that this is the ejection fraction less than 22%, 23 to 32, up until greater than 52%. And you can see that the lower your ejection fraction, the annualized incidence of major events, in particular death. For example, here we see the black line, which is non-cardiovascular death. That doesn't change so much. But sudden death, if you have a low ejection fraction, increases enormously the lower your ejection fraction. And heart failure death, which is this crossed pattern here, increases with the lower ejection fraction. In fact, the mortality in this group increased by 39% for every reduction in left ventricular ejection fraction below 45%. So the left ventricular ejection fraction has a really good prognostic element to it. Here's another one, which is even a bigger study. It's a meta-analysis looking at survival from heart failure. As you can see, there's nearly 4,000 patients and 40,000 patients in this study, covering 30 other studies. And as shown here is that as your ejection fraction decreases, now here's a good ejection fraction, 55, 60%, but as it decreases down to less than 20, then your mortality ratio increases enormously. And in fact, it's doubled here compared to what it is here, and so on. The other interesting thing to notice is that if your ejection fraction is above 40%, which we would still regard as mildly impaired, your mortality, in fact, is not that much different to having a normal ejection fraction. These are just to say that these changes in ejection fraction, for example, here's the ejection fraction less than 30%, the red line 30 to 39%, ejection fraction greater than 40%, even if you take into factors such as blood pressure, as shown in this bottom left-hand graph, or over here, looking at your age, the lower your ejection fraction, the higher mortality. So if the left ventricular ejection fraction is so important, how can we measure it? And there's a number of ways of measuring it. I'm going to group this first four together because we can basically ignore them. And the reason we can ignore them is that when we look at the heart, for those of you who do echocardiography, you'll find that, in fact, this is the way in which we can get an ejection fraction from what we call the long parasternal view. We get the M mode picture, we do a couple of measurements, and lo and behold, the machine gives us an ejection fraction, in this case, 58%. Now, the reality is that all those 4 methods are all flawed by the use of a single left ventricular end diastolic measurement. What they do is to take one line of ultrasound across the base of the heart, as shown up here. We transform it into M mode, and from this, with clever calculations, the algorithm determines what the ejection fraction is. But in all honesty, in the critically ill patient, it is really nonsense. What you have to do is you have to look at the whole of the left ventricle. Here's a left ventricle, here's a poorly contracting left ventricle, and what we would use is the Simpson methods, which divides the left ventricle up into multiple discs. Here it is at the end of systole. Here it is at the end of, this is the end of diastole, end of systole. You use both the apical 4 chamber, the apical 3 chamber, and the machine does the calculations for you once you trace out the endocardial border, and that will give you an ejection fraction using the so-called Simpson's method. Now, the Simpson's method is very widely used. It's commonly used. It's used every day in cardiology practice. It's got prognostic value, as I've pointed out to you. So what are the limitations in the intensive care unit or the emergency department? One is that you don't actually have good endocardial definition a lot of the time. So how do you actually track around the endocardial border when you have a somewhat of an indistinct endocardial border as shown here? It might be that you're holding your probe in a slightly wrong position, and we have what we call apical 4 shortening, whereas rather than cutting up through the middle of the left ventricle, we're sort of cutting at a slight angle. There's a lot of geometric assumptions, which we'll come on to, and of course arrhythmias can affect the way in which you assess the left ventricular contraction. Now, for example, even if you measure it accurately, you've got good endocardial border delineation, it might be accurate, but it can be quite misleading. For example, here's a left ventricle cross-section, and here's the left ventricle, and you can see there's really marked left ventricular wall hypertrophy. That's about 20 millimeters in thickness, the normal one being up to 11 millimeters. The contraction looks good. But the trouble, although the contraction looks good, the remodeling that comes about from this thickening of the muscle causes reduced myocardial shortening, and in fact, your ejection fraction does not actually relate to the overall function of the left ventricle during systole. The second group, of course, is the chamber size. You can have a really small chamber with a very good ejection fraction, but in fact, you've got a very small stroke volume and a very small cardiac output. Conversely, if you have a very big left ventricle, the ejection fraction might be quite small, but your stroke volume, in fact, is equal to that of a person with a normal sized ventricle because of the fact that the amount you eject during systole is equal to that of a stroke volume in a normal heart. Can we improve the measurements of left ventricular ejection fraction? Yes. The two ways of doing it are using 3D and contrast. These are not really available to everybody, excuse me, but they are techniques that are available in the more sophisticated laboratories. Here's a 3D where in fact you still have to delineate the myocardial border. You have a 3D picture, you get a sort of a cartoon like this, and it can measure the ejection fraction for you by measuring the end diastolic volume and the end systolic volume, in this case giving an ejection fraction of 22% and a stroke volume of 37 mils. The other way, of course, is to inject contrast. And now we have contrast that will go through the pulmonary circulation and will in fact end up in the left ventricle. And you can see now how much easier it is to delineate the border of the left ventricle, and so it's much more accurate in measuring the left ventricular sizes. Does it make a difference? Well, yes. Your gold standard for measuring your left ventricle ejection fraction is the MRI. And if we look at the MRI compared to using 2D echo, you'll notice that the agreement is really quite poor. It's about 12%. So you can have up to a 12% error in really most of the cases that you can do. Once you use 3D, you reduce that area down to 4 to 5. So 3D can certainly make a difference. So what else can we do? What other ways can we measure the left ventricle other than using the left ventricular ejection fraction Simpson's method? There are a number of methods, and I'm not going to go through them all. Those who are very interested in echocardiography will be familiar with a lot of these techniques, but I'm just going to go through how useful they may or may not be. First of all, you can use M-mode, Doppler, tissue Doppler imaging, or global longitudinal strain. If you're using tissue Doppler imaging, we use something called S-velocity, S-prime velocity. The reality is it's only really moderate value. It's not really that accurate. It's okay to help you, but you would not rely on that alone. One using tissue Doppler imaging that can be very important in certain situations is the pre-ejection method, where you measure the time difference between the QRS onset to the pulmonary valve opening and that to the aortic valve opening. And of course, that's what you give people biventricular pacing wires for, to try in fact to have coordination of ventricular contraction. And you can measure to see whether this is useful in those patients who are critically ill, who have a low cardiac output. Is the answer not giving inotropes, but in fact adjusting their pacing parameters in their pacemaker? And this is probably really quite underutilized because people don't really know that much about it, but it can be very useful in those subsets of patients. The big change these days is speckle tracking and using strain. And in speckle tracking, what we do is we actually look very closely at the change here, and we end up with pretty pictures like this, getting global longitudinal strain, which are very helpful in determining the contraction of the left ventricle. However, the critical care physician has to ask, is this the correct question in the hemodynamically unstable patient? Are we that interested in left ventricular ejection fraction, or are we more interested in the cardiac output and the cost of achieving that? Because the two may not be related. Just to remember, you can have a low ejection fraction, but the prognosis can be quite different depending on what the underlying pathology is. So what we have to do is to assess other things that are very important in the hemodynamically unstable patient. One is the cardiac output, the other is segmental wall motion abnormalities, left ventricular diastolic function, and left ventricular outflow tract obstruction analysis. Cardiac output, you can use the VTI of the left ventricular outflow tract. It's a very accurate method for cardiac output. Segmental wall motion abnormalities, very important to see whether it's a reversible condition like Takotsubo syndrome, or are you dealing with underlying ischemic heart disease. And so in summary, if you're going to look at systolic function using the echo, yes, you should be very quite comfortable about using Simpson's method. And of course, if possible, if you can find some way of improving the accuracy, then do so. Secondly, you should use tissue Doppler imaging, not necessarily for the S-prime, which is helpful but not that accurate, but to see whether you can get some understanding of the diastolic function, which is an important part of the overall analysis of left ventricular function, particularly cardiac output. There are timing techniques that you could use. Speckle tracking has become very important. It's not available on all machines, but as the years go by, then I think most critical care physicians will be learning how to use this. Segmental wall motion abnormalities, to decide if there's underlying coronary artery disease or not, and is there a need for this patient to go directly to a coronary angiogram and possible stenting, is very important. And to finish off, ask yourself the question, is it the LVEF that really I'm looking for, or am I looking at the cardiac output? And if I am, can I get some measurement of that or some surrogate measurement such as the LVOT Doppler? And so in summary, that's my final slide. And just to remind yourselves that if you're using echocardiography to assess left ventricular contraction, there are a lot of things you can pick up other than just using the left ventricular ejection fraction on its own. Thank you.